So please, instead of having a round of introduction, I guess you'll save time by having everybody put down your information and contact information in the chat. Please include your name, your email address, your organization, so we can keep in touch. Anytime, please raise your hand or write to the chat if you have any questions. And the last thing before we start is we have a webinar in French covering similar content. The date is to be decided yet. If you know anyone who will be interested, please stay tuned and spread the news. So today we will first have Monia from Swiss Red Cross talk about the MHPSS roadmap and the digital MHPSS pledge to give us a framework on why we are here today. We will then have three good practices from within the movement to share. Next, myself and two other colleagues from the LSE will present a report, the report we did for Swiss Red Cross and the IFRC on digital MHPSS within the movement, in particular the challenges. And then we will have a panel discussion on the challenges and what are some ways to overcome them. We will then talk about some of our recommendations from our side, from the consultancy project. We'll finally wrap up and cover some next steps. So without further ado, I'll now pass the time to Monia.
Thanks, and good morning, good afternoon, good evening, everybody. I wish you a very warm welcome to this webinar on challenges and best practices from digital mental health and psychosocial support in the RCRC movement on behalf of the Swiss Red Cross, but also the MHPSS Roadmap Initiative. My name is Monia Ebersold, and I'm a digital MHPSS program manager at the Swiss Red Cross, and I'm also co-leading one of the working groups of the MHPSS Roadmap. And I would just like to give you some context information so that you understand why we're here today and how this LSC consultancy project came to happen. Well, the Swiss Red Cross, as you will hear today, is just one out of many national societies that have decided to explore new pathways to respond to the significant level of unmet needs in MHPS. But not only national societies, but also our leadership from the RCRC movement has acknowledged an increased urgency in increasing our capacity, but also capability to respond to those unmet needs. And therefore, in 2019, as you all might know, the International Red Cross and Red Crescent movement has adopted a resolution and a joint policy to address those unmet mental health and PS needs of people affected by armed conflict, natural disasters, and other emergencies. And the overall goal of the resolution is to increase action in MHPS needs and make mental well-being a priority in humanitarian work. And to implement the resolution and the joint 8 policy statements, an MHPSS roadmap from 2019 to 2023, now probably 24, has been developed to provide an overall guidance for the movement on how to build a more harmonized and also holistic response to those MHPS needs. And with this joint agenda and its 6 priority action areas that you see here, that have been turned into 5 working groups, we are trying to ensure that everyone will have early and sustained access to quality mental health support. And I'm not going into detail with those all those priority action areas. I'm concentrating on priority action area 4 today, because this is the work group the Swiss Red Cross is co-leading together with the PS Center. And the overall goal of our work group, priority action area 4, is to support national societies in developing quality intervention so that more people can be reached with appropriate support. And we want to put a special eye on innovative approaches such as digital services. And now you can continue this 2 slides, please. You can jump this one and go straight to the next. Yeah, thank you. At the same time, At the same conference in 2019, the Swiss Red Cross has also submitted a digital MHPSS pledge with very similar intentions like the roadmap. And with this pledge, the Swiss Red Cross has committed itself to share in the innovation, the technology, but also the many, many learnings that we had out of our own digital intervention that we developed in the past 2 to 3 years. So we want to share these learnings and also the technology and whatever comes with it with other organizations within the movement. That's what we committed ourselves to. And it's with these two initiatives, or it's in the context of these two initiatives that we merged together, that the cooperation with the London School of Economics has come about. It's the 4 students from the LSE International Development Consultancy Project that conducted and analyzed lots of stakeholder interviews over several months with representatives and practitioners from various national societies, but also from organizations outside the movement. And they have produced an extremely comprehensive and exciting report, and a short version of this report, a management summary. And they're discussing the most important findings and showcase good examples with us today. So this is the baseline. Their work is actually the baseline for our future work in the movement on digital MHPSS. And I'm going to talk a little bit more about the next steps at the end of this webinar. And I'm giving back the stage to you, Camille and Loretta. Thank you.
So we will now hear 3 organizations sharing about their experiences about implementing digital MHPSS, and we will first begin with the Australian Red Cross, and John Richardson is going to present for that. I think we cannot hear you, John, you're muted.
How about that? Can you hear me now? Are you hearing me okay?
Yes, we can hear you now.
Yeah. Oh, yeah. Good. Yeah, sorry. Oh, that's not what I wanted to share. Why is this? It's worked before. Why is this not working? So sorry, folks. How about that? That looks all right, doesn't it? Great, thank you, and sorry for that. We thought we had it in hand. Yeah, Shona Witten, who has left us, so asked me if I could come along and have a chat with you about. I suppose it's not. It was interesting. It's not necessarily MHPSS support tool. But we do have a sort of digital application which sort of helps us with our sort of preparedness. But because we sort of take a psychosocial approach to preparedness rather than sort of a sort of strictly sort of practical approach, I think that's where I think she's spoken to you previously about this, and that's why there's sort of a little bit of interest. So so yeah, I thought she said, oh, it'd be good if you could kind of talk people through that. So yeah, as I said, we have a what we coin, I guess, the term of psychosocial preparedness approach, which we think is sort of fairly unique, not only sort of within the movement, but sort of across the sort of sector, with sort of most sort of preparedness activities sort of focus on the kind of practical and sort of survival, whereas I suppose what we do, and I use this slide, which is from The Secret Life of Walter Mitty, where so Cheryl says to Walter, when he's sort of trying to work out who's sent him this strange sort of photo, well, in my crime writing class, we start at the end and work backwards. And so that's how we've sort of tried to sort of approach sort of preparedness, which is sort of looking at the impacts and sort of effectively sort of, I guess, what people are left with, and then sort of try and work backwards from there and sort of look at the potentially the advice, the messaging to people to sort of make to try and make things like reduce the impacts. And so most of the sort of preparedness activities we sort of see are focused on people not dying, which is really good. You know, it's a thing we want to happen. But what we've been sort of thinking, we've sort of really been influenced by is this kind of image. It's okay, but what happens next? So people are left with this, and so that's where our messaging is sort of really focused on sort of the long-term impacts. And I suppose what we've been trying to do as we as a program have sort of matured over the past sort of decade, but probably in the last sort of 5 years or so, is how might we apply the 5 psychosocial pillars of support in a preparedness sort of context. So thinking about safety, calm, connection, self-efficacy, and hope, looking at the actions that actually contribute to those. So safety is sort of pretty straightforward. Knowing your hazards, knowing where to go, evacuation routes, those sorts of things. Calming, we sort of promote psychological preparedness sort of techniques, which have about anticipate, identify, and sort of manage stress. So I won't go through all this, as I know I've only got 10 minutes, so, or less than 10 minutes now. But so we've really tried to ground sort of our preparedness in these sort of pillars, and so that's kind of formed, I guess, the basis of our program. We started out probably like everyone else. Let's do a pamphlet or a booklet. Let's start to talk about it, and then we've kind of moved on from there. So you can see it's launched in 2008. The little girl in the corner there is my daughter. She's now currently traveling on her own around Turkey, so you can kind of see that that's how long ago that image was taken. But I guess getting to sort of where we really want to be is what we when we did a review about sort of 6 or 7 years ago. This was really when sort of digital technologies were sort of starting to sort of emerge. Of course, everyone said, well, let's do an app, and so that was kind of what so everyone said, oh, we've got to go and do an app. Because everyone else had an app. So, but we did do some work, so trying to work through to make sure that was that the sort of most appropriate solution. Unfortunately, with sort of one of our sponsors and sort of partners, the Insurance Australia Group, they were able to sort of help us with kind of developing sort of a digital solution. And so that's started out with sorry, somebody's trying to ring me, go away. So that started out with sort of really trying to look at what people would want. So we undertook sort of audience research with a group of 20 people selected sort of from different walks of life. We developed sort of a range of personas, and then we sat down with people again to sort of try and co-create this tool, building off the messaging in sort of Ready Plan, the Ready Plan as I showed in the previous slide. So really kind of the basics were, these are sort of some of the things in there, but probably the key thing here is when you look at that middle kind of image there, who are my key 3? So what, I guess, a cornerstone of our sort of preparedness messaging is connection is the key. So, you're more likely to rely upon people who are your neighbours and passers-by than say the official emergency services, and so we kind of really wanted to develop that as a key part of the app. And so what this does is it allows you to identify 3 people who might be able to provide you with psychosocial support. And so that, and they may not be people who are necessarily close to you, but you can actually kind of put them into the app and message those people. Then there's 3 people who you might provide you with practical help. So they might be closer by, and you can rely on them to come and help move something or whatever. And then there's 3 people who you might provide help to. So this, I guess, is where it's where we sort of see its strength as getting people to sort of think about the kind of psychosocial dimension of disasters, where they have to sort of identify people who might be able to provide them with sort of support and sort of reassurance, not only during but sort of post disaster. And then look, this is just, I guess, this is the what you can then do is then once it's finalized, you can share it. And so then what it does is it sort of allows you then to sort of do more. So connects into other content that might be on our website. So where we've got our sort of prepare your mind content, it links you to do and undertake those actions. But that's sort of more of a kind of one-way sort of activity. So that's really it. That we've developed this. We've got I think probably around about 35,000 downloads. We're currently going through a sort of review process to look at what might we do next with it. Potentially we might be looking at a more kind of web-based act, like a product rather than an app, because we have heard that apps can tend to clog your phone up if they're not used a lot. So that's something that we're certainly sort of thinking about. So thank you. I'll stop sharing my screen.
Thank you so much, John, for presenting. I think we will have a moment of Q&A a little bit later, so we can combine all the questions together and try to answer them the best that we can. Now we will hear about the New Zealand Red Cross, and Pip Mabin and Kate Keville are going to present.
And maybe Pip and I didn't really talk about who was going to go first, I have to say. But kia ora koutou. My name's Kate Keville and I'm the psychosocial team lead. So my role is to deliver training, psychosocial training, mental health training to organisations. It's sort of our commercial side of the organisation. And Pip?
Kia ora koutou. So my role is in the emergency management and international team. So I'm the psychosocial support advisor there. And so I work with our disaster welfare and support team volunteers. So we have 19 teams, about 350 volunteers throughout New Zealand.
So we're taking it, we've got slightly different angles. So I'll share our bit to do with the external training, and then Pip will just share a little bit about what we do for internal volunteers. So it all happened for New Zealand Red Cross very suddenly. It was when New Zealand went into lockdown a couple of years ago due to COVID, when suddenly we couldn't deliver our courses face-to-face. And so it literally, that's where it all started from my perspective. And what we were doing is that we just couldn't deliver, but we still wanted to get the message out of the psychosocial messages. So we literally shoved something together very quickly in the first week, whilst not knowing any technology, never heard of Zoom before, really didn't actually know what the heck we were doing. But we started off with offering the psychological first aid course for a 1 hour. We sort of just reduced, obviously, the content right down to that. And then we also subsequently, in the week or so later, sort of stressed well-being and resilience, because those were the two key things that we really wanted to get out there for people to continue, especially when they were in lockdown. So we didn't have a budget. We didn't have a plan. It was all, we didn't have any skills to do all of this. It was literally reactive to the situation that we found ourselves in. So we wanted to make it safe, we wanted to make it accessible, and we wanted to make it interesting. So, we did breakout rooms, having all sorts of interactions. We had a follow-up, sort of like a workbook that we emailed after the course, and sometimes now we email something before the course. So there's things that we've adapted along the way from that. And I suppose now going forward, we still offer these and offer online solutions. It's now we're looking at the wider options of giving our learners how they can learn face-to-face, a little bit of online, or a combination. So that's where we're at from external facing. And Pip might talk about the internal.
Yeah, thanks. I'll just get my microphone off. Yeah, thanks, Kate. Kia ora koutou.
Pip, you're muted again. I think it's when you put your head down.
Okay, is that better? Here we go. Okay, so just wanted to describe what we've done with some PFA training for our disaster welfare and support team volunteers. So the team members all received the one-day basic PFA training. One of New Zealand Red Cross's mandated roles in an emergency is as a psychosocial support agency. So it's something that we are often requested to provide in communities that are experiencing disaster events. So our volunteers have a one-day basic PFA training that was developed about 2013, 2014, thanks to our colleague John and his colleagues at Australian Red Cross. We were able to build on the Australian Red Cross PFA training and the Australian PFA guide and adapt it to the Aotearoa New Zealand context. So our volunteers, over the years, I guess we've been getting a little bit of resistance from the volunteers about having to do the same PFA course every 2 years, because we ask them to refresh it every 2 years. We think it's really important that they keep their PFA skills fresh. And so really that was, and also we were wanting to introduce more variety to keep the volunteers motivated with that training, acknowledging that it is one of our key roles. So we decided to introduce a two-part refresher course, where part one was a self-paced online learning module, which could be done on the New Zealand Red Cross online learning platform, and part two, a face-to-face, mostly skills practice, so case study discussions, scenarios, role plays, that kind of thing, to build those, to build the skills. So we were able to do that last year, early last year. It took about 4 to 6 months to develop. It wouldn't have been so long, but again, we were restricted by the COVID lockdowns in terms of the piloting process. So, I should explain, part one is the self-paced online learning module. Part two was originally designed to be a face-to-face module, but again, due to COVID restrictions and lockdowns, that became a facilitated online learning module. So a total of 4 hours as opposed to the original one-day PFA course. It took about 6 months to develop. We contracted an online learning developer who happened to be also one of our disaster welfare support team volunteers, which was great because she really understood the context. And so it took about 60 hours of her time, plus some time of the company that manages our online learning platform, plus some staff time, of course, to pilot and administer once it's up and running. It wasn't hugely expensive, about 4,000 New Zealand dollars, which is about 2,500 Swiss francs. So one of the things we really wanted to do, and this was because we wanted good buy-in from the volunteers around the training, was to try and make it participatory. So we involved them a lot in the piloting of the course, and also with the online module, quite a number of the pages are narrated by our volunteers. So again, really trying to increase that sense of involvement with the course. It's, in terms of accessibility, it's quite easy for our volunteers to access through the normal volunteer rescue app that they use to log their training hours, and also to register for training horses. In terms of evaluation, I think we've got fairly rudimentary evaluation. So we can get the metrics from the use of the online module. And also there's a basic survey at the end of the online module. We've had really positive feedback. We think, we've got a level of confidence that it's reasonably successful as a training experience. But I think really interested, the next steps for us would be around evaluating online PFA training versus face-to-face training in terms of its effectiveness in skill development. And so, yeah, that's something that I'm really interested in pursuing, and would be interested in kind of learning more from this group, if any of you have experience in that. Thank you.
We haven't approached the practical side of the PFA online, like the activities and the actual role playing, for want of a better word, right now. That's something that, again, we haven't quite sort of got our head around how what that could look like. So our components are either just purely the education, just this is what it is, this is what sort of the bit of the theory and the evidence supporting it is what we do, and then we do the practical. Here are the tools, there are the, the 5 pillars, the look, listen, link that we use in the face-to-face. So that makes it that practical one for us. So short and sweet, I think we are from New Zealand. I don't know if there's any questions later on, we're happy to answer.
Thank you so much, Pip and Kate, for presenting the experience of the New Zealand Red Cross. We are going now to hear from a project between Bobbelberg and the Danish Red Cross, and Andreas Wagner from Bobbelberg is going to present.
Yes. Hello, everyone. Can you hear me? Perfectly. I'm just gonna share the screen, so if you would let me know when you can see this. Can you see it right now?
Yes.
Perfect. As Camille said, I'm not from the Danish Red Cross, but I'm from Bobbelberg, as it's called in Danish. But we are in a collaboration with the Danish Red Cross, as you can see in the logo in front of you, Bobbelberg, and sammen med Røde Kors, which means in English together with Red Cross. Bobbelberg is a digital platform to real-life community. All across Denmark, users use Bobbelberg to find communities, all kinds of communities, through our platform. It works in that way that you sign up, as you can see at one of the screens. You use your name, then you use your municipality where you live. Denmark is a small country compared to one of the other countries in this, but still it's necessary to use to show where you live. Then you sign up with your birth year, so we can compare where the society should be at, your email address, and then your personal access code. Then when you do that, you came into this like bulletin board of all kinds of communities and societies. It's users all across who make posts where they write what they need, kinds of societies. It could be a food club, it could be a travel partner, it could be someone to run with, it could be all kinds of things. It's also available to download in App Store or to Google Play. so use it for an app. Some of the themes you see on your left right now is what the users are using Bubblebug for. It's commonly loneliness, it's integration, it's family problems, someone who needs a mother or a grandmother for the children. It's mental health, which getting a community all is. It's foods, it is about food and meals, it's about culture, nature, and also about sports and exercise. So that's a lot of things, and that's the thing with the Bubble Bear. It's actually all kinds of communities that you can find. We don't put limits on our users. You can search for whatever you want. It's your own post, so you can write whatever you want in that. Though we do use some boundaries, I will come back to that later. Member growth, you can see here we started the platform in 2015, and the first many years it was not in a collaboration with the Danish Red Cross, but after 2 years back when we started, we decided to get this collaboration mainly because that, yeah, with the Danish Red Cross and we had the common goals to fight loneliness, to get more into societies, and therefore secure some mental health for the Danish people. So from 2018 and to where we are now, we had a huge member growth, almost a 500,000 uses the platform here in Denmark to find societies. But an important thing to say about this curve, as you can see, it really rises in 2018 where we started this collaboration, is that one of the important things that we did was to be physical presence in the communities in Denmark. So in the start we only had the digital platform and people could use that, but now we are also a part of events and festivals, as you may know here from Denmark, is a big thing. So that being a physical presence is an important thing of Bubble Bear, to meet the users of it and meet the Danish people and tell them how they could use Bubblebug to find societies. So it's not just a digital platform, it's much more than that. Some of the ethics to security is about Bubblebug. It's we are the data controller. It's not like you know from many other sites like Zalando when you visit that last night and you now are joining your Facebook or Instagram or whatever you use. Now you see commercials from Zalando everywhere. Not at Bubblebug, there is no commercials at Bubblebug, and we are the data controller. No ads, as I just mentioned. All the platform is no ads free. So that also makes us a bit safer for our users to use, and they don't feel that, okay, I joined Bubblebug now, but all my data is being sold further. They feel it as a secure place. We have the WCAG 2.0, as you may know, to little AA, which means that the blind people can use Bubblebug, and people with epilepsy, it's called in Danish. I actually don't know what it's called in English, but blind people can use Bubblebug to find communities also. And as I mentioned, there is some boundaries using Bubblebug. You can use it to find every kinds of societies, but there is 2 societies that you can't find. You can't find your next girlfriend. You can use all kinds of other platforms for that. There's plenty. So we are screening and monitoring of all content at the platform and messages. It's mostly because that our users are coming to Bubblebug to find societies, and it makes a mixed picture if there's someone at the other side of the table who are writing to me, I can see that you're looking for a running partner, but I also search for a girlfriend or a boyfriend. Couldn't that be something? So to secure that, we're checking it. We have a bunch of banned words like sex and violence and all this kind of stuff, when they are being sent in Bubbleberg, we get a pop-up in the back, and we can delete the user like that. So that's actually the most important thing for us. It's to secure that it's only good societies at Bubbleberg. That didn't show well. Now it does. To be a bit more secure on what we do and how did we help the people, we made a report from, I don't know if you know it, Økonomer Uden Grænser, it's called in Danish, which validated our platform and looked into what we do for the Danish people. And as some of the main points I just showed here, it's like 26% of the people who visit Bubbleberg is because of loneliness and to find friends. 40% of them feel less lonely after creating a bubble, which is a tag on Bubbleberg. 76% of them meet physically when they have met people on Bubbleberg. That's an important number for us. And the most important thing is actually the one at the right, that the social return on the investment when you decide to use your money for Bubbleberg is that 561% of it came back to you after over 4 years. So it shows that when you as a community show to invest in Bubbleberg, it gives you a lot of social return on invest. Last view is that I just decided to, but we already did it in the chat, my info here if you want to reach out. We are looking for Bubbleberg. It's only in Denmark, but we are looking to cross the borders and searching into other countries than Denmark. So reach out if this could be an opportunity. Thank you for your time.
Thank you so much, Andreas, for presenting. We will now hear from Loretta from our team of LSE about the results of the challenges that we encountered during doing our report, the challenges about digital technology, and then we will go on to a Q&A session. Thank you.
Thank you. We are Camille, Soledad, and Loretta. We are master students from the London School of Economics. Earlier this year, we have conducted a research for the Swiss Red Cross and IFRC on the question, how can the movement effectively leverage digital technology to improve MHPSS? Before we share some of our findings, we'll first briefly talk about how we conducted our research. We conducted this research and 32 informant interviews with researchers and practitioners from around the world. Some of you in the audience here were also our informants. So 20 of our interviewees were from within the movement and 12 from outside the movement. As you can see on this map, we have interviewed people from 24 countries spanning all continents. We're hopeful to have achieved a meaningful geographical balance, making our findings somewhat representative of different contexts. So to look at how can we leverage digital technology for MHPSS, we first asked ourselves, what are good practices in digital MHPSS interventions? We established an original analytical framework encompassing 5 key dimensions: safety, effectiveness, scalability, sustainability, and participation. Each dimension consists of several facets, which highlight key determinants of the success of digital interventions. This framework is developed based on several existing guidelines and manuals by the movement, RCRC, IASC, and UNICEF, in addition to practical concerns emerged in our exchanges with the Swiss Red Cross and IFRC. In the interest of time, we will not go through the facets under each dimension now, but we are most happy to return to it later. This analytical framework is not meant to be exhaustive, but to serve as a guide to sketch out how does a desirable digital MHPSS intervention would look like. We see some of these traits in our presenters' interventions just now. We will now move on to talk about what challenges did we find among our informants in making the intervention safe, effective, scalable, sustainable, and participatory. In terms of safety, the first challenge concerns data protection. Data protection and anonymity are key, especially for vulnerable users, as the information provided, for example, during online consultations, entails highly confidential elements on personal life issues that can come with stigma. Revealing such information could severely harm service users. This is of particular importance as digital MHPSS interventions can be potential targets of data theft and hacking. These issues also come hand in hand with the issue of commercialization of data. Indeed, national societies might be inclined to partner with private businesses to overcome technical challenges or finance gaps. But if the agreement entails commercialization of data, it jeopardizes the confidentiality of service users' personal data. Second, national society report challenges to ensure that the interventions do no harm. Digital MHPSS interventions may cause unintended harm to users when misused, or when digital MHPSS is employed in contexts where MHPSS is highly stigmatized. For example, one national society offers crisis support to young people by using a specific hashtag on social media. This may, however, expose the service users to stigmatization or abuse by publicly identifying the vulnerability. Moreover, digital interventions need to be updated to remain safe. For example, outdated information can give wrong directories for national psychological or psychiatric support. Third, digital MHPSS interventions may fall short in delivering effective crisis care. While digital interventions allow for more flexible and immediate access to care, they also enable more abrupt break-off of contact, reducing the scope of immediate intervention in acute crises compared to face-to-face consultations. The second aspect concerns effectiveness. In relation to positive impact, the evidence base for digital MHPSS is far from complete. While there are plenty of evidence for specialized mental health interventions like online psychotherapy, there is a gap in the literature regarding the effectiveness of digital basic psychosocial support. Furthermore, many trials are conducted in clinically controlled settings or higher income countries, therefore limiting their generalizability. The use of digital technology for MHPSS in limited resource settings still requires substantial research. In terms of acceptance, the sustained engagement of service users is a critical factor for effectiveness, which is even more challenging in digital interventions, especially those that are unguided. Some factors affecting how users interact with the intervention include the length of the intervention or how credible the provider is. Lastly, the third challenge concerns cultural appropriateness. When an intervention is not socially or culturally relevant for the target population, it results in lower engagement and acceptability. Therefore, when implementing an intervention originally developed for a different target group, it is essential to adapt it to the local context and target audience. However, this process entails its own challenges. Adapting existing self-guided interventions such as apps and websites requires alterations to the program's code, which might be protected by copyright or is difficult to access. Even when a code is accessible, alterations require a lot of technical expertise. Substantial alterations might also make the evidence base the intervention rests on become obsolete. This would have important safety implications. Even if the adaptations are more subtle, tailoring them to the target group can be a bit challenging, such as finding the right terms and adequate tones for translations, or tailor promotion strategies to target the right group of people. The third main aspect is scalability, and there are two main types of challenges under scalability: accessibility and resource limitations. There are potentially multiple barriers to make digital MHPSS inaccessible to the user groups. Structurally, a primary concern is the lack of internet coverage and/or end devices for service users. Socially, mental health issues are still highly stigmatized in many areas. Some service users might not have sufficient privacy within their homes to confidentially access MHPSS services. This is true in many low-income contexts with overcrowded housing, and is most acute in refugee camps. For example, survivors of domestic abuse might find it difficult to use digital MHPSS within the vicinity of their families. Politically, in some cases where stigmatization is politically institutionalized, there could be severely repressive mental health legislation that dispossesses basic rights of those who seek help. Even where stigmatization is not institutionalized, there can be bureaucratic hurdles to scaling interventions, such as different regulations between different provinces. Finally, there are barriers concerning literacy. For example, it could be difficult for children, marginalized groups, and people in certain low-income countries to use automatized interventions such as mobile apps. There is also some concern for lacking digital literacy, often faced by older persons. Arguably, the biggest obstacle that national societies face, however, are of course resource limitations. It requires a lot of funding, staff, and expertise and time to develop digital interventions. One informant estimated an average of 3 years from inception to launch for an intervention. Additionally, they require long-term funds for promotion, maintenance, and enhancements. Next up, for sustainability. The first challenge pertaining to sustainability is temporal sustainability, whether interventions can last in the long run. Echoing what we said in the previous slide, digital MHPSS may entail high long-term costs for maintenance and enhancement. Interventions that app or web-based require constant updates to improve improve user experience. Update information, for example, local service directories, maintain compatibility with IT software and hardware, for example, whether the app is compatible with the iOS, comply with changing regulations. Maintenance and updates also require substantial staff time. For those that require less specialized and professional knowledge and are performed by volunteers, the instability of their contribution can negatively impact service delivery. Where inputs by specialized staff, such as psychologists and psychiatrists, are required, the lack of long-term funding could jeopardize their presence, and with it, the safe and effective implementation and evaluation of interventions. For example, a virtual reality intervention against chronic pain was planned and delivered in several RCRC physical rehabilitation centers in South Asia. But in one country, the project was suspended due to the removal of a psychologist from the team. The second challenge lies in limited embeddedness in existing local structures. A systematic review of 14 studies evidenced the difficulty of institutionalizing new MHPSS innovations. Of course, the structural sustainability of digital MHPSS hinges on the existing IT and mental health infrastructure and personnel. In areas where these are low, it is imaginable that there were considerable difficulties in delivering structurally sustainable digital MHPSS initiatives. Finally, for participation, with less monitoring on the use of and compliance to the intervention, there tends to be a higher dropout rate in self-guided interventions as compared to MHPSS with more non-virtual elements, such as in-person interaction. For example, one national society reported instances where users who seek help via chatbots disengage mid-process. And surprisingly, it is also more difficult to retain users to participate in the evaluation process. At this juncture, we'd like to turn to a panel discussion on challenges and solutions. We can first quickly clarify some technicalities of the interventions if there are any questions or confusions. Our speakers would then share a bit about the challenges they encountered in the process of designing the intervention, what they wish they knew, or lessons they want to share with others, so that other national societies wouldn't have to repeat the detours they took or can get to success quicker. So we're now past the time to our speakers, and Soledad, who will moderate the session.
So I think that if anyone has any technical questions about the design of interventions, we can cover that before we move to the discussion. So if everyone has any questions. No. Okay, so I think that we can start the discussion with a very simple question that will be for our speakers. What is the most important thing that you have done to enable the success of your intervention? Anyone want to start?
For us, it was, if I could start, it was the physical presence, being out there, not just being a digital platform, but being physical. It really helped us. It gets the users more secure with us, and establish like a not a friendship, but that we know our users. We have many of them, but that we get access to them. So the physical presence.
I think for us it was spending the time and the money. I mean, there's money involved in it as well. Spending the time in the kind of design and testing sort of phases, because our initial sort of start on this was like I said, I think somebody said, oh, you know, we've got $50,000 and we can do an app, and our digital manager said, sure, you can do that. And then when they started to look at what it wasn't very good. Like, it was for $50,000, it was no better than sort of a website, which was not what people wanted. So being able to spend time and have people come in and co-design and do the user testing and develop the personas and that sort of thing certainly gave us a lot more confidence in sort of where the sort of product ended up. But I think also then to Andreas's sort of point is then what do you do with it next? So we linked this to our sort of annual preparedness campaign. It kind of became a sort of focal point of what we were trying to do. So made that sort of the centre point, and it became sort of like the easy action for us to be able to talk about was actually what we want you to do to get prepared is to download the app. That's your action, because then from there things sort of should then sort of follow out. So yeah, you need to spend time certainly in development.
Yeah, I think for us, and I mean, as I'm talking about the training with the volunteers now, I mean, it's not as an intervention as such. It's a step back from that. It's training volunteers who are then going to make an intervention, PSS intervention. So, but I think there were two things. I think one was around the involvement of the volunteers in the development process of the course. I think that was definitely one. And I think the other was we were just fortunate enough to have a contractor who understood our context. And actually that was really valuable.
So just related with this, if you had to start again, what would you do differently? Yeah. And what would you have wished to know before, even if you did in the same way?
For me, what I wished was like, it's the technology and the knowledge, because I suppose we're a bit different. We weren't designing an app, it was literally training and just it was on the run. So having any knowledge of technology and how that would have been really helpful going forward, and planning, and maybe, you know, having more time to plan. Because our intervention was really quick and for a specific reason, that it was just a bit rushed, really, to be honest. So a lot of more time and money and thinking around what's going to best meet the needs of the clients and our people who are participating, so that they can go out and provide PFA to their people. Yeah, so that would be my thoughts there.
I think for us is a bit similar to what Kate and people were saying. Is sort of having a bit of technical nous, or at least having somebody on your team who has this technical nous to know when to say no, we don't want to do that, or this is what we want to do. And I think we, to be quite honest, I think we got pushed towards the app solution because that's what everyone was talking about. Everyone was talking about apps. You know, you had to have an app. And I think, you know, there is some argument that some of the things that we do could be just done in a web-based sort of solution, and which is what we're sort of exploring now. So we do invest quite a bit of time in sort of getting the app. So and I take your point, Loretta, in the and we might get to this anyway, but in the research is that because some of the problems we were having with the app, and it was kind of built a couple of different times, was as soon as you want to make some really simple changes, that it's either difficult or costly, and we need we need to be flexible. I think if we're looking at sort of the provision of support, yeah, you do need to be sort of you need to have that flexibility. You need to be able to do it reasonably quickly and for us without cost. So that I think is a challenge. But Solidated, we're probably getting into challenges, aren't we?
For us, this must be listening to the users. The funny thing about Bubbleberg is it actually started back in 2015 as a sport platform where you can find a sport partner. But then we got like 2,000 people into the platform and say, hey, you can search for sport partners now, but none of them did. So in the years, we actually built many kinds of things for the users, but we didn't listen to them, what they needed. And one of the things they needed was the app. So we actually used 2 years to make that, and now we have it. But I wish we would have known before that listening to the users is the most important thing for us. It's the one there that are using our product.
Anyone else, or should we move to the next? Yeah. So it's also related with this. What do you think that was your biggest difficulty, and how did you overcome it in the process of developing and implementing?
I think for us, it like, even though I said take the time to do it, but it was a very long lead time as well. So we had to sort of manage this sort of pressure of we were doing this project and people wanting it done quickly, and then sort of doing it over a long period of time. I think the other thing for us was because our approach to preparedness is quite unique. We were really wanting to focus on the key three and sort of like being able to bring in the psychosocial elements, and yet our partners who are an insurance company who are very much sort of more focusing on the practical, you know, where's your 3 liters of water, where's your kits, and those sorts of things, which these are all the things we know. So kind of managing that tension was certainly challenging. So a lot of that is investing up front about I think, you know, we need to be able to bring the technical experts in to set the context and sort of say it's not just good enough to put it in a brief. You actually need to sit and take people through what it is you want to achieve and why it's important. So you impart the nuance. I've only ever seen like one sort of creative agency over my years in doing this work who have got a brief like that and said, oh, I get what you're on about. You know, I get that this impacts on people's mental health and well-being. So everyone else is really more about you know, we've either got to scare people or yeah, we just got to stop them from dying, which of course, as I said before, is a good thing. So yeah, you do need to invest, really do invest in briefing people in so that they kind of understand sort of what it is we're working on and managing expectations. So again, you've got to spend a lot of time on that.
And John, if I may add, in regards to the Get Prepared app, one of the challenges is that we're all discussing digital platforms, but a lot of our communities are still not comfortable with technology. And so even though we are talking about an app or websites, etc., there is a huge challenge and an opportunity to roll hard copy flyers, resources, and blend it with the conversations with the grandparents or those who are from a lower literacy level who don't have access, that we can really link together using conversations, hard copy flyers leading into the technology. And that certainly has been a winning formula to overcome that difficulty.
Yeah, I couldn't agree more, Linda. I think that's such a key thing. We had a project that was looking at digital literacy, and it is surprising how limited it is, particularly if you're going into rural and regional areas and parts of urban areas as well. That's why I liked, Andreas, when you talked about your data management and ethics. I think that is really important for building trust. And so, yeah, people don't want to hand over their data to Mark Zuckerberg or whoever it is. And so being able to kind of, say that, I think is a really important part of sort of building trust in a product, because we're bombarded every day with all sorts of stuff, as well as we're bombarded with people kind of saying, is this safe? So I think that is really important.
I would have sorry, Kate.
I was just thinking too, I mean, ours is a different perspective as well as with the training, but it was an interesting situation where when it was even sometimes there was a little bit of a disconnect internally, if I'm honest. So like where I sit is within our commercial first aid. So we're out there delivering training and getting money into the organisation so we can do all that sort of support stuff. And so we were the only part of the first aid organisation able to try and get some income coming in whilst everyone was in lockdown, because we couldn't do any first aid training. But also Red Cross, quite rightly so, wanted to have psychosocial messages and things going out to communities and having all this offering for free. So there was a disconnect between, but we can get it there for free, but you're going to charge us this per person. So there was that we had to sort of try and manage, which was hard, I have to say. Just both important but competing priorities.
Monia?
Yeah, sorry for just speaking up. I really appreciate a lot the way of not commercializing our products, but then my question to Andres would be then, how do you guarantee sustainability? How do you finance your product for like a long use if you're not selling data or if you're not commercializing?
In Denmark, we have like 98 municipalities. I don't know if you have any recommend in your countries, but it's like Copenhagen is like one municipality, and Aarhus and all like the big cities has municipalities. It's like regions in some of your countries. We collaborate with them, so they pay an amount for us to all of their users can use Bubbleberg with no limits. It's not like when you don't live in a municipality where we don't have a collaboration that you cannot use Bubbleberg, but you have some limits. You can write to users. You can join Bubbleberg. You can see the communities, but you have some boundaries and limits. And we actually do this because then we don't need to go selling data and have commercials and all these kind of things. So thank you.
Any other questions related with this? No, okay. So we can wrap up the discussion, and I will ask all of our speakers to tell us what is your biggest takeaway or recommendation for the audience.
Mine would be, because we're talking about training, is making it short, tight from a time perspective, clear, purposeful and interactive. So engaging with the audience so that they do learn also from what the information that you're trying to deliver. So that would be my wee takeaway.
My takeaway would be that now I'm not from the Red Cross, but I'm from Bubbleberg, but we have a collaboration with the Red Cross and as I mentioned, the municipalities. The biggest takeaway is for us not to being, for the other part also, is not to be a supplier for each other, but being a partner, help each other and develop things together, and not just like we have this digital platform and Red Cross came along, but they help us like mention new things and getting to new places like festivals and all those kind of stuff. So being a partner and not a supplier for each other is the biggest takeaway for us.
Yeah, I think mine would be all of those, but also yeah, making sure you're setting the context really well and doing the groundwork. So we were obviously able to do that, and not like Kate and Pip where you had to do it quickly. But I think invest in setting it up right, and as Andreas has said, and kind of listening to users. So yeah, worth sort of putting the time into that.
Yeah, and I think I would again all of the previous ones, but also add to around sort of not seeing the digital as a complete replacement. I'm really interested in, everyone's kind of mentioned also the role of face-to-face or hard copy or whatever, and acknowledging that it's not going to suit everyone. And so looking at what can be done really well digitally and what can't, and what else needs to be in place as well.
Thank you very much to all of you. And if someone, before we move on, has any last remarks, comments, anything, otherwise I will pass the word to Camille, that is going to present some of the recommendations that we proposed in our report after having done the research. So thank you very much again to everyone. And
can you hear me? Okay. So now we will discuss the recommendations emerging from the finding of our report. And first, we're going to see the current landscape of how digital MHPSS is already being used as of today. So based on the interviews that we did, we gathered detailed information on 37 digital MHPSS interventions, 24 within the movement and 13 outside the movement. And what we've learned globally is that at the level of basic psychosocial support, we saw the strongest use of automated digital interventions. And this includes a wide range of tools, from social media posts to educational videos, instructive podcasts, website, mobile apps, and chatbots, which require minimal human input and are therefore highly scalable. And an even wider range of technologies is used for focused psychosocial support, though here there are also more forms of remote human-to-human interaction, such as hotlines using phones, video calls, or messenger apps. And the use of digital technology thins out the higher we go in the pyramid, as you can see on the pyramid here. But there is also a considerable body of guided mobile apps and websites based on cognitive behavioral therapy, which have a strong evidence base and are being used for psychosocial support. And at the level of specialized mental health care, the most common use of digital technology we see, certainly also increased by COVID-19, are video calls to conduct remote individual treatment. But the human element here is in many ways central in the process. And referral systems that refer patients to intervention of this level also leverage digital means. So in some digital MHPSS is already being used to a fair extent by the movement. And we saw that the higher we go in the pyramid, the less digital technologies are being employed and the more human supervision becomes central. And this limits the scalability of top-tier interventions, but is certainly warranted by safety concerns and the fact that the user base also decreases towards the top of the pyramid. And now we will pass to the, we'll go to the recommendations. So following our research, we have advanced 6 recommendations to the movement and the IFRC. The first one is to ensure safety and improve service delivery. National societies should collect and leverage data in both quantitative as well as qualitative ways. So where possible, providers should consider integrating automated monitoring and evaluation into digital interventions, such as moon tracking of service users throughout time. And the data gathered should be leveraged not only for scientific research, but also for needs assessment and planning. Second, hybrid models of intervention should be favored. Combining digital and conventional MHPSS modules will often emerge as the optimal option, as both formats can reinforce each other within a same intervention. Third, available digital tools should be adapted. Indeed, developing reasonably complex, safe, and adapted digital interventions require substantial staff, finance, and time, as we've discussed already. And therefore, national societies should instead make use of the unique advantage of digital tools by replicating available ones. And therefore, we thought that a mapping of existing digital intervention in coordination, notably with academia, should be conducted to establish first a whitelist of safe, effective, and evidence-based interventions, and a blacklist of unreliable interventions. And both lists should be updated and disseminated amongst donors and national authorities. National societies should also focus available resources on making necessary adaptation to local culture using a human-centered and participatory approaches. And the IFRC should also establish a movement-wide MHPSS Innovation Center that could centrally develop, maintain, update, and evaluate new open source digital interventions that are warranted by international needs. And this will minimize marginal costs for national societies, which is also interesting. Now we will move to the 4th recommendation. Thank you. So 4th, the movement should engage in principled partnerships to benefit from the diverse perspective of universities, local community actors, philanthropic organizations, governmental agencies, and private companies. And each of these have important expertise to offer, and we believe that national societies could gain a lot by partnering with them. And in the later case of private companies, business humanitarian partnerships should be critically assessed according to the movement's guidelines. 5th, the movement should build synergies with local structures. So digital MHPSS intervention should be integrated holistically into national strategies and structures to build synergies within the broader health system. And this would allow, for example, the task transfer within MHPSS between the movement and the broader health structures. And it could also enhance referral options to specialized services. Intervention should also aim at building local capacities. So for example, experts, preferably from the local community, should be included initially to build the capacities of local volunteers through a train-the-trainer format. And where the institutional environment creates barrier to digital MHPSS, the movement should also partner with local stakeholders to advocate for destigmatization and enhance legislation. Finally, the last recommendation is to enhance the quality of care and the well-being of staff and volunteers. And the IFRC Psychological Center should develop standard operating procedures that guide practitioners engaged in digital intervention and train and supervise them in their implementation. If we can move to the next slide, please. Thank you. So here we have synthesized, and this is also in the report that we produced. We have synthesized practical guideline that contains solution proposals and recommendations in terms of content and organization of implementation when implementing a digital MHPSS initiatives from the design phase all the way to the evaluation. So as you can see from the left to the right, you can observe all the milestones that have emerged to be key to be considered when implementing digital MHPSS. In the interest of time, we're not going to go through it thoroughly here, but we are most happy to come back to it during the Q&A. So to conclude, in this report that we have produced, we have laid out how digital technologies can be leveraged to overcome the persistent gap in MHPSS provision in emergencies and beyond. And despite their potentials, there are several challenges, as Loretta presented, faced by practitioners when implementing digital interventions. Based on the analysis of these challenges and their possible solution, we have proposed 6 practical recommendations in the report. And we found in particular that digital tools are often best used in complementarity to face-to-face interventions, and that digital tools are valuable not only in direct treatment, but also for coordination, advocacy, awareness raising, data analysis, and so on. Even though digital tools can help bridge to a certain extent the current provision gap, closing the gap and providing optimal care in the long run will also require much increased training of mental health specialists. And we are well aware of the limitation of this research. However, we hope that this can contribute to a growing dialogue.
All right, it's my time to take over again. Thank you so much. I really want to take this opportunity to formally thank you again for all this valuable work that you did, you guys from the LSE, and especially also to create this opportunity for exchange for us. Many of the learnings that I heard today, I can sign straight away. We also went through so many of these learnings, and I think during the last 2 years in the project, we realized how important it is, this exchange, and to network with people, because I think if we exchange more and if we can build on each other's learnings, we can kind of avoid many of the detours that we all made. So this is why we would really like to initiate an institutionalization of this process of exchange, and have a systematic kind of institutionalize the exchange. And this is why we would like to create a work group. This is all under the umbrella of the MHPSS roadmap. So our goal is to use the work that has been done prior by the Australian Red Cross, but also by the American Red Cross and the LSE now, to build and create a community of practice. And what the work group is actually supposed to do is to help develop a common strategy for sustainable tech products in the RCRC movement. I'm sorry. And the work group can be in charge of assessing the needs and requirements for such MHPSS tech products on different levels of the pyramid, as we heard, but also in the different contexts we are working. And it should kind of be like a sounding board for this process, to create sustainable business models together, and to integrate also the products into existing structures, to see how we can learn from each other and map good practice and share with other national societies that would want to go digital. So this is kind of a community of practice, and we are very well aware of the lack of resources for everybody. So the work will be done mainly within the meetings that will take place once a month. There's not much work that needs to be done in between. It's really supposed to be a community of practice that helps capacity building, like based on guidelines that we can co-develop, and then facilitating. Like, for example, the Swiss Red Cross has developed our application on an open source software that we are very ready to share with others and to provide to other national societies that may use it, as well as the content that we develop. So this is a kind of a platform where we can share not only experiences, but also resources. I'm sorry. You can go to the last slide, please. No, jump one more. Thank you. So what would be the next steps? I would really like to invite you to join this initiative by either being part of the work group, and the work group will start end of September. We will have a first work group meeting where we organize ourselves, where we develop a TOR for the group. But if you need more information on what the work will be or will look like, or what we are intending to do under the umbrella of the roadmap, you can join the kickoff meeting that will be held in English, Spanish, and French on the 6th of September, where we will give more information. And if you feel like your national society is already engaged in digital MHPSS, you are also invited to join or to sign the pledge, the digital MHPSS pledge, with the Swiss Red Cross, the Swedish Red Cross, and the IFRC PS Center. So please feel free to get back to me. You'll find my information on the very last slide that we will share with you. Don't hesitate to get in touch with me also in case you have questions or you would like to know more about the next steps and this process. But I would really, again, make a call for action so that we can continue this process that we have started now and continue this community of practice where we can share experiences, learnings, and also our resources. That's it from my side. We thank you very much for your participation, for your input, and I wish you a very nice rest of the day or night or evening, whatever it is at your place. And as I said, don't hesitate to get back to us in case of questions or whatever it is. We are here for you. Thanks a lot. Bye. Bye, everyone. Thank you so much.
Thank you. Bye bye.
Thanks very much. That was great.
Yeah,
Thanks.
thank you.
Thank you.
Hey, how was it for you?
I think it went smoothly.
Very smooth. It was perfect. Also the timing, it was just perfect. And it was so interesting, really. I think it was a good, it was a good mix also of the people and the services that they were presenting. It was really nice.
Yeah, I just panicked a little bit at one moment in the discussion because it felt that it didn't flow, but at the end, it worked.
No, perfectly. It was really, and for outside, it's you as a moderator, but from outside, it wasn't a problem because they jumped in, they came in, so it was perfect. Hey, thank you so much.
Don't worry. Are you also presenting this afternoon?
Yes, I am. And this afternoon, I'll also present SUI, right? I'll
Yes.
present our interventions. Yeah, good.
Great. Then I'll see you in a few hours.
Yeah, see you then. Are we joining again 10 minutes earlier?
Sure.
Or is it? Yeah, okay, good. See you then. Thanks a lot.
Thank you. See you.
Bye, guys.
Thank you.